I invite now Nicolas Wentzensen to present another scope of future molecular testing and its potential impact, how this could change screening and triage over in the next future.
Good morning. My disclosures: I am evaluating new assays for cervical cancer screening, in part donated or achieved at reduced cost, but I have no other conflict of interest, and those are not official NCI statements. So to talk about the future potential impact on, of molecular tests, it's important to look into the past as a starter, and it's actually a reality still in many countries in the world. Cervical cancer screening is based on a primary, or was based and still is based on primary cytology screening, followed by colposcopy and biopsy, and then histology to decide which woman should be treated for precancer and who can be referred to screening, and all those steps are very subjective and have low reproducibility, and so the promise of molecular tests is to have markers that are directly linked to the carcinogenic process and that are robust and more reproducible across different populations. The first molecular test introduced into this screening paradigm was HPV testing for borderline abnormal pap smears, or ASCAs. There has been a lot of work on improving histology assessment using molecular tests such as P16. And as we all have heard, now primary HPV DNA testing is being recommended in many countries in the world, and is being introduced in some places, or has been used as co-testing for a couple of years. And of course, the big question now is, what are we doing? We have this great tool as a primary screening that tells us if you're HPV negative, you don't need to come back for a long time, but if we are HPV positive, we need to figure out who we send to colpo biopsy and so on. So this is the big question now. What are we doing with HPV positive or HPV positive cytology negative women? There are a large number of biomarkers that have been evaluated over the last decade. They're all linked to the natural history of cervical cancer. HPV infection is the first step, and so HPV DNA detection is present at all those steps, from HPV infection to precancer and invasive cancer, and a lot of those other markers, both cellular markers and viral markers, occur at later steps, more closely linked to precancer and closer to the invasive cancer that we are trying to prevent. So there are markers of chromosomal instability like 3q amplification, several proliferation markers, MCM2, TOP2A, Ki67, there's P16, host and viral methylation that has come up in recent years and is very interesting, HPV integration and HPV oncogene mRNA, and also HPV oncogene protein testing. And all those markers have been evaluated in different studies, and the evidence is very heterogeneous for a lot of those markers. It's impossible to go through the whole list in this talk, so I'm just going to highlight a few of the markers that are currently considered for triage, or that have been recently developed and that are very promising for development of assays. So HPV 16, 18 genotyping is the first one that I'm going to talk about. I'm going to show a few slides on P16, and also I'm going to briefly talk about methylation, and then later I will show how they could be integrated in new screening algorithms. And again, there's different methylation assays that have been developed, and over recent years, some groups have focused on host methylation, and Chris Meyer just showed some data, and there's a recent publication from the Dutch group by Snellenberg looking at a 3-marker multiplex assay, whereas we and a number of other groups have looked at viral methylation as marker, and I'm going to show some of that data. So starting off with HPV genotyping, we've seen that many times, variations of this graph from different studies from the from the Danish cohort, and this is again from the Portland Kaiser study, looking at risk of CIN3 and risk of cancer in relationship to different genotypes. And 16 has the highest risk of CIN3 over a long period of time, and 18 as well, whereas the other types are much lower. So those are very good risk predictors, but they're not direct markers of a precancer, because they could be just a transient infection or a precancer as well. So that's a difference to a lot of the other markers that I'm showing that are more specifically associated with precancer, but they show a very high risk of precancer. P16 is a marker of transforming HPV infections. It is linked to the actions of HPV oncogenes, E7 disrupting Rb, leading to a high increase of P16 expression, and those are different applications shown here. In histology, this is CIN3 that is strongly and diffusely stained with P16 through all layers, and this is a kind of a benign lesion that doesn't show any staining. And there's a lot of data showing that using P16 in histology can help to adjudicate pathology, can pretty much serve the same goal that pathology panels serve, kind of getting a more reproducible diagnosis of the slides. And those findings have recently been integrated into the revised guidelines for nomenclature of cervical abnormalities, the last guidelines, and those guidelines recommend adjudication of CIN2, the most heterogeneous group of the histology categories, and only consider P16 positive CIN2 as a precancer. So this is now being implemented in the US, and it will be very interesting to see how it will be applied. P16 has also been developed into a cytology assay, and recently it has been expanded as a dual stain to stain for both P16 and Ki67. Importantly, both stains should be detected in the same cell, so there's a nuclear stain for Ki67 showing cell proliferation, and then the P16 stain that indicates the HPV oncogene action. And there are a couple of studies that have evaluated that assay. And it is important to note that the current P16 assay, it still has a subjective component, so it's not as objective as we would like to have a biomarker like HPV testing, but there is definitely a potential for automated cell evaluation of P16 stain slides. This is a study that we recently published from the NCI, looking cross-sectionally at P16 in a colposcopy referral population, where we showed high sensitivity of the dual stain for both CIN2 plus and CIN3 plus, around 80 to 90, well, around 90% for CIN3 plus. And in this population, theoretically, colpo referral could have been reduced by half, but this is obviously not the prime application, and I'm going to show another example a little later how in a revised screening setting P16 could be used. Finally, I want to show some exciting data, but much earlier compared to the other assays I showed on viral methylation. We have done whole genome methylation of a number of carcinogenic types, starting with HPV16 and then extending to those 3 types. And we have a couple more types coming out of the pipeline now, and I'm going to talk more about that during the meeting. The red bar, so this is the whole genome covering from the URR to L2 and L1. In the back for all those 3 types, and we see the methylation levels are especially high in L1 and L2, and the red bars, the red portion of the bars show the difference between CIN3 and women without histologic abnormality that have the same type. So there's a big difference in those levels, and those p-values shown here by the dots are very low, showing a really high significance of the differences. And we looked at individual sites and how they would predict CIN3 status compared to a infection with the same type that has no histologic abnormality, and we found really good discrimination for individual sites. And now the next step will be to combine assays across different carcinogenic types and evaluate those in a unselected population, not caring about individual genotypes. So this is kind of more general. What is the impact of molecular markers on screening? So this is something that we already have heard a lot about and that we have seen. The key message here is that if we have molecular markers like HPV testing that are very sensitive and that act very early in the carcinogenic process, we can extend screening intervals. And this is kind of the old PAP-based screening approach with 35 to 50 screens per lifetime. And then we have co-testing, recent US guidelines, reducing the total number per lifetime, assuming they're all normal, no abnormalities, to 11 screens. If there is primary HPV screening, it can be reduced further, and so on. And maybe sometime in the future, although we heard that this hasn't been recommended at this point, but there might be a shift towards adapted screening process in vaccinated women and reducing that further. So all those scenarios have comparable or even better cancer prevention than the old PAP-based screening approach, but they have a lot less screens per lifetime, and they have a lower risk of referring somebody and treating somebody who does not need to be treated. The same, we're trying to do the same now on the management level. So this is the next step among women who are HPV positive, or in the US guidelines here, this is kind of the slide. Women who are HPV positive but cytology negative, we do not want to send those women to immediate colposcopy because most of those women will have transient infections and will not need to be referred. So the current guidelines recommend repeat co-testing after a year, and then if either of the two tests is positive, refer women to colposcopy. The alternative management is HPV DNA typing. If women are 16 or 18 positive, they should be referred to colposcopy immediately because of the much higher risk of HPV 16 and 18 for precancer. But the goal of molecular markers at this level is to reduce unnecessary colposcopy referral and also to try to extend intervals and to avoid frequent retesting. Often women are being re-referred to colpo every 6 months or every 12 months. So there's a lot of, once you're in this diagnostic machinery, it's very hard to get out. And so that's something that we want to achieve with molecular markers and refer as many women back to regular screening as possible. And this just shows two recent studies looking at exactly that step, looking at triage options for HPV positive women. One is from the Athena trial paper that Phil published last year, and then data from the Italian screening trial by Carozzi that was published a few years ago. But Dr. Ronco has presented 3-year follow-up data on the P16 data here, and the follow-up manuscript will come out very soon. So what is important here is to look at a number of things. So first, an important message here is that the risk in the two populations was quite different. So if you look at all women in those studies were referred to colposcopy, and in the Athena trial, the risk in test positives was almost double or even a little higher than in the Italian trial. So that makes it a little harder to compare those absolute risk measures, and that's something we now see in many of the studies that we compare, that the risk levels, although there are comparable populations on paper, the risk is quite different. So important measures are referral rates, what's the test positivity, how many women would be referred to colposcopy, and we see a range for ASCUS from 27% in the Athena trial to 45% if we consider HPV 16 or 18 or ASCUS positivity, which actually is the co-testing recommendation in the new screening guidelines. So this is the range here. The risk for the different strategies in test positives is about doubled for most of the combinations, and the baseline sensitivity ranges from 53% for ASCUS only, indicating that there's still a large population that has precancer that hasn't been found with ASCUS, to 78% with a combined approach. And in comparison, we see for P16 There's also doubling of the absolute risk among P16 positives. We have a fairly high referral percentage, so the test positivity is quite high. Again, it's in the same range as the current co-testing recommendations, and the sensitivity is higher than the other tests that are up there. But again, those two studies, there's a grain of salt comparing those. So to finish up, just one comment on low resource settings. There's been a lot of technical improvement and a lot of advance in technology, and if we have a useful biomarker, there is a way to convert it to a robust and low-cost assay, and that has been shown for carrier HPV, and there is an oncoprotein E6 test that Phil and others are evaluating in low resource settings, and tuberculosis testing, PCR-based, has shown that even complex assays involving PCR can be converted to a very robust setting, and that is very promising. So if we have a good marker, we should try to get it into a format that works in low resource settings. So to wrap up, what we want to do with molecular markers, we want to send back more women to regular screening. We want to do less in women with low risk, so we want to reduce both risk in women that are tested negative and that are tested positive, because we don't want to treat somebody who doesn't need to be treated. And also it's important to move to low resource settings, and that is a very hypothetical screening algorithm, very simple, with a primary screening that is very sensitive, a very specific molecular test. I'm not naming anything here, and it's an ideal world without lawsuits where Walter Kinney doesn't need to worry about the $2 million. So that's the future where we want to get with those assays, but there's a lot to do. Thank you.
Terrific. Thank you, Nico.